Today's topic is on HSG. We normally pick up a topic which is quite irrelevant actually, about which people don't talk, but they don't use it. It's something akin to being in a library as a librarian, where you have books all around, but you don't read the books because you don't have time. You're only issuing books to people. So HSG is one topic about which everyone wants to know, everyone wants to learn, but somehow we are not able to know about it much more, and it's a dying art. When I joined the practice, they said that breech is a dying art. Same way HSG is a dying art, but as an old timer, I feel it's the most important part of the whole infertility treatment which we should be considering. So a brief background of ICEAT. ICEAT works with a vision. It works with an idea to simplify things. All of you who have joined us would agree that we don't believe in putting things in a mixer and making some nice turmeric paste and giving it to people. So everything should be fresh, full of ideas. Let the fresh air come in, and that's the way we say we all learn from you every second day. Removing the knots from the life. So I always believe that we have to remove the knots, and these knots are where they are in our mind and nowhere else. The agenda is removing the knots and keeping things very simple. Digital platform is the one which we chose around an year back, and it actually was encouraged by having COVID scenario in our country and globally. And that's the way we started our work. And we started around a year back, 1.5 years back now, Pooja and me, and now we are gradually progressing from 2 to nearly 500 students all over the world. Thank you, Pooja, for this. Now, once we look at the whole scenario, you look at how is a learning pyramid. And what Dr. Jyoti brought out so beautifully some time back, that we are having more of a Pathshala. Dr. Jyoti has been one of our brightest friends, always checking us and coming back to us with ideas and guiding us. I think she'll fully agree what I want to express here today. When you want to teach people or learn from them, from a lectures you don't learn anything actually. Lectures are the most boring part everywhere. In case you want to see something on, so suppose you want to learn something, how to cut an onion, simple thing, how to cut an onion, peel an onion. You will get minimum 50 videos on YouTube, how to cut an onion. But that's not the concept we want to follow here. We want to go much ahead of that. And as we move ahead, you'll find that from lectures to reading and to teaching others. When you start teaching others, so you are our teachers in some way. When you start teaching others, we learn 90% of the content. This is the amount which we retain. And so keeping that in mind, learning pyramid, we thought about having the CSR classes every alternate Sunday. And as you find that we have around 250 to 80 people joining us every Sunday morning. We are starting with 189 now. Before I move ahead, let's have an icebreaker round. Can any one of you tell me what they see on the screen? Any one of you. Here, everybody is same. We all are learning, and HSG is a dying art. I just want to ask you, what is arrow showing you?
Air bubbles, sir.
Air bubbles. Very good. So this is air bubbles. It's so beautiful. I'm so happy that is not a dying art. Thank you so much for responding in such a positive way. So gentlemen, ladies, what we see here are the air bubbles. They are not polyps. They are not filling defects. They are the air bubbles. So beautiful, so beautiful. So that's the way we want you to move ahead. And today, I'll be keeping myself off from the theory part. We'll only see some good pictures and correlate how to interpret an HSG film. So full marks. Can you identify yourself? Who said air bubbles?
Dr. Sushil Shinde, sir.
Hi Shinde, how are you? How are you?
I'm
good
good,
morning
sir.
to you.
I'm good, sir.
So good morning, everyone. We are touching 194 now. 194 friends are there now. I can't actually scroll through, but thank you so much for being with us and thank you for talking. moving ahead. These are our courses. We have multiple courses on basic IVF setups and lab setups, on andrology, IUI, IVF. We have a virtual university. We have multiple YouTube channels. YouTube channels are not for you to subscribe and to get more members. It is you to learn how to talk to your patient. This is part of our CSR responsibility, where we train doctors how to talk to the patients. Sometimes they feel that it is for getting your own recognition. Now, it's not like that. It's a part of our CSR where we train doctors how to talk to their patients. We have one on clinical, we have one on embryology. 2 are there. You can go and visit. At peak of the COVID, people were having not a lot of money. So we started with COVID scholarships, and we gave nine fully paid COVID scholarships in the month of March, April, May, worth around 5 lakh rupees to people. That is part of our CSR. Resonance series have been brought up. There are 4 of them. I think you would have already got the books with you. If you don't have, let us know. This is for the people and by the people. This is what you are creating, and this is our payback to you for being with us. And we do complete formatting and planning of these resonance series for you. Any one of you can pick up a topic and come forward. This is the one which we are releasing today, and I would take blessings of Dr. Jyoti Kalakoti to release it once. Ma'am, just release it. Shagufta is not here, so this is on hysteroscopy. You can say I'm releasing it, and people will get it in their.
So I'm lucky to get this chance also, sir. So I'm releasing this resonance. This is part 4, I think, and it is on the role of hysteroscopy in ART. I'm really great to release this resonance also, sir. Thank you so much.
Thank you. By now you would have got it on your.
Thank you, ma'am.
And customarily, what we do is that after every curtain raiser, we'll send you all relevant articles in the world as latest as half an hour back. Whatever matters in the world in the field of that specialty is being shared with you. That's part of our CSR, and not actually just educating yourself, but it's part of our responsibility towards the society. So we had our first CSR on plastics, where people don't talk about plastics actually. So we spoke on plastics. And then we had topics like microscopes, about which people don't know. We spoke about air quality, spoke about OPU needles, ET catheters. We spoke about IUIs and so on. IUI protocols, Guerrero drop-ins, we had a curtain raiser, luteal phase defects we spoke, azoospermias, IUI tips and tricks. Then we spoke about adjuvants or add-ons. And today we are speaking on HSG. And next curtain raiser is the one which is very, very near to my heart and a lot of demand from everyone. That is about the hormonal assessment. Hormonal assessment in a patient. This I've kept it on 15th of August. This is a tribute to the country. So now soenge na sone denge. That is our concept we have. So you should be with us. Coming next 45 minutes, I'm gonna shift to topic for today. So what is HSG? There are 3 things which we commonly talk about. We talk about SSG, we talk about 𝐬𝐤𝐬𝐬, and we talk about HSG. So SSG is just putting some saline inside in the uterine cavity. I don't like this test much because it doesn't give you much of inputs and ideas. You just look at some fluid going from where it is going. I'm not very happy with this, but people do it, you can do it. 𝐬𝐤𝐬𝐬 is putting contrast. This is a good test, but again, not a very, very fine test, very expensive. And we can do 5 patients at one time from one bottle, and we can't store it for more than 3 to 4 hours. That is the problem of this. So we have to collect 5 patients together and then we do it. The bottle costs around rupees 5,000. It doesn't work out much presently in our scenario. For an individual gynecologist, yes, for a big lab, it's okay. HSG is the one which I always say, it's the Waterloo. Once you learn HSG, you can really do a good job. So today's talk is not be about what we use to, how do we do HSG, what dyes we use, what BDs we use, but they're all water-soluble dyes we are using. The water-soluble dyes are taken 4 to 5 ml, sometimes 6 ml, sometimes we dilute it, sometimes we put it directly. This is a kit we use, a tray we use. I prefer to use this cannula like this, which we can actually screw in the cervix. So I feel very happy with this. And I think that's it. So introduction, what we won't talk today. What we won't talk today is very important for me. I won't talk about TB diagnosis. So please, I request you that we'll remove TB from our mind. How do we diagnose? What is interferon? What is X-ray? That we won't talk about that, because the topic is not on TB. Procedure we won't talk about. Procedure we all know. We all have been doing HSG, so we won't talk about the procedures by any means. So my take will be very simple. We know that we have two fallopian tubes here in this corner, and then we have the uterus, and then we have the cervix, and we have vagina. So we look at, when we start doing HSG, when I ask people, what do we learn in HSG? The answer is, we look at the spill. So spill is the last thing to be seen on an HSG, is the spill, last thing. When we start doing an HSG, always start looking at the cervix. How are the arbor vitae? What is the shape of cervix? And when you look at the cervix, you start getting these shadows here. I'll show to you these pictures. Look at the cervix. Look at the cavity. How is the cavity doing? In the cavity, do we have any irregularity? Is the cavity lining regular or irregular? This you have to see. Do we have any filling defect, which are not air bubbles, as you rightly brought out? After that, we look at this junction. This is istemo-uterine junction. This junction is a junction where the endometrial cavity will end here, and then we have beginning of the tubal cavity. Look at this junction. This is very, very important. And it normally, when you look at this junction, the junction will normally look like an inverted triangle to us, and this we will just show to you as we will look like something like this inverted triangle. Let's show you some pictures. Look at this junction. Look at the waves of the tube. Now, once we have the tubes going, how are the tubes going? Are the tubes regular? Are the tubes rigid? Are tubes going like this? And this we call as the primary waves. Are the tubes going like this? These are called the secondary waves. And are the tubes sometimes going like this? This is called the tertiary waves. So moving away from only the spill here, move away from the spill and look at all these things. Then what do we see? We always look at the type of spill. Is the spill going and getting spread along the gut, or all the spill is loculating somewhere around? This you have to see. After this, we look at the tubal musculature. When you look at the tube, when you look at the ischemic junction, you'll find tube is like this. But as it goes towards the fallopian end, ampullary end, you'll find folds in the tubes. These folds have to be checked. They normally have around 4 to 5 folds are visualized here. These folds can be seen. So in the tube, we look at whether the tube is straight tube, rigid tube, or the tube is having primary waves, secondary waves, or the tube is having tertiary waves. And you'll agree that when we have multiple waves, this is a good tube. That's very important. When we see the mucosal folds, we are happy that tubes muscularis mucosa is perfectly fine. So when you look at the folds as the ischemic junction, we'll have something like this in the tube. And as it moves towards the ampullary region, you'll find that tube has got multiple folds. And when we look at what can go wrong in a woman, what can go wrong if you look at it, her uterus may have some problem with the endometrial cavity. The cavity may be, the lining may be bad. There can be some polyp lying inside or a fibroid lying inside. There can be a coronal spasm or coronal block here. The tubes which we have like this can become affected by tuberculosis or some disease, and tubes can become abnormal. Now, how does the tubes become abnormal? Uterus is very easy to understand actually. There's no problem with the uterus, but look at the tubes. The tubes have got endosalpinx layer. Like we have endometrium here, you have endosalpinx here. Now, when we have, and this will look like something like this. Now, what happens that once we have any infection coming here, when there's some infection coming here, or any calcification coming here, the tube will be eroded. Now, what we'll get is, we'll get something like this, and we'll have, so this will be an out pouching in the tubal muscle. So tubal muscle will be out pouching here like this. Initially, you'll find regular rugosities, but when we have the breaching of the endosalpinx, you'll find that we'll have such pouchings occur. And these pouchings are evidence of salpingitis. When these pouchings occur here with infection, and finally due to the infection the tubes, it gets choked. It can lead to dilatation of the tubes here, and that is called hydrosalpinx. So by no means, I like to talk to you about hydrosalpinx. Hydrosalpinx, anybody can just see and say there's an hydrosalpinx. Spill there or not, anybody can say, but we're going to move one step ahead today. We will look at the different pathologies and understand that it's a beautiful method. HSG is such a beautiful method that got a lot to learn from it. So one by one, we look at the multiple causes of the problem. But is it really good? Is it good doing an HSG? My answer would be yes. I think all of the women, they deserve an HSG. And how we work the patient at our center is that day 9 of the periods, we normally call her. Important here is that her follicles should be more than 7 to 18 millimeter. Because until the follicles are not mature, the endometrium is not formed. So follicular size, this is around 20 millimeter, is directly proportional to the cervical mucus and proportional to the endometrial thickness. In case you get a patient with PCOS who's got 20 follicles of 10 millimeter each, the endometrium won't grow. For making the endometrium grow, it's very important that we get follicles of around 20 millimeter. Only then we'll have E2 range of around 300 picograms, and then the endometrium starts growing and proliferating. So the day her follicles become 70 to 18 millimeter, that's the day. Maybe day 9, maybe day 12, she's ready for the further workup. And the workup will be, in the morning, we carry out her 3D color Doppler, or a 2D, depending upon if we don't have any finding, we do a 2D color Doppler, and then she goes in for HSG. Very simple method. And by this method, we don't miss on anything actually. We don't miss anything at all nowadays. We have entirely eradicated hysteroscopy and laparoscopy. In case you're doing these things, they are operative. Otherwise, you don't do any diagnostic DHLs. So what I want to tell you is that in case we combine 3D color Doppler or a 2D or a beam mode done properly with proper hands, we combine them, we won't miss anything. So once you look at the HSG is one of the most common modalities, but it's a dying art. People are moving away from hysteroscopy nowadays, but remember it works very well. I'll hysteroscopy under
Sir, you are mute.
somebody is muting me. Somebody is muting me repeatedly. So you will have to understand that doing a fluoroscopy is the best method to carrying out an hysteroscopy. Because of that method, when actually align our uterus left or right, pull the tubes, traction them, or move them in the AP dimensions. Now there is something called sensitivity and specificity. These are numbers which may vary from 75%, as you can see here, to 96%. I think I'll move away from the numbers. And these numbers can be pretty high, but it all depends upon how much we know about an HSG. In case you are not aware of, in case you only look at an HSG as a tool, when you look at the spill of the fallopian tube, then there won't be any specificity or other things. So today we have to learn how to interpret an HSG, then only we can have better outcome. So looking at the uterine problems, tubal problems is a beautiful thing, but we want to go beyond that today. We are not here to look at an hydrosalpinx and say, okay, this is an hydrosalpinx. This is not in my mind at all, that anybody can do. Laparoscopy can be eradicated. We are not here to eradicate any technology. We're not here to eradicate any hysteroscopy, but just look at it, that a cost of an hysteroscopy is rupees around 35,000. Approximately. And a laparoscopy, if you combine, they add another 50,000. The whole procedure you end up paying around rupees 75,000 approximately. In case you carry out 3D and HSG, total expenditure can be around 7,000 to 8,000. 10 times less. And what you can make out is much more than laparoscopy and hysteroscopy in case you do it properly. Laparoscopy, our main concern is looking inside the tube, which we can't see by carrying out hysteroscopy or laparoscopy. We can only look at the cavity and the abdominal cavity. But by doing a 3D and other things, I think it gives a beautiful outcome, less invasive, both are complementary, and gives you a very good result. In case you find something wrong here, then definitely we go in for bigger procedures. So do it in the follicular phase. Only one tip, don't do it anytime. Do it in the follicular phase and always rule out pregnancy before you do it. Because once we start doing it, we find that where we don't expect anything, that lady is pregnant and then we have problems. Very good. So it's a method we do it, and don't use excess of dye. I've seen people taking 10 ml and just injecting. Don't do that. Take around 3 to 4 ml, gradually put, and in case you have fluoroscopic guidance, it's so pretty. You can actually seeing things expanding in front of you. Even if you don't have that, start with around 3 to 4 ml only. First fill should only show you the uterus. Don't be in a hurry to look at spill. When you do an HSG, answer is spill aa gaya, spill has come. Tubes patent, take out, off. That's not the way. Patient is under stress, relax. In case you find, in my whole career, I would have done less than 0.1% under anesthesia. But in case required, give anesthesia also, give some minimal ketamine into it, give her some compose. But one thing is for sure, make her relax. In case she's not relaxed, then she'll have coronal spasm. Then again, you'll have a blockage. Then you'll go for laparoscopy again. So make the patient completely relax, and that's very important for all of us. Minimal amount of dye, minimal pressure. Now we just take one syringe and just press. We want to just put in a lot of media inside, a lot of force, and then we want to open the tubes. A lot of us have got an idea that by forceful expulsion, we'll open the tubes. So yes, we open the tubes, but before that, before you open any tube, before you actually break open the synechia in the tube, I request that at least identify the synechia. You say, yes, there is a problem, I'll try to break it open. And what people do is just push in 10 ml Then they get complete intraposition, extraposition like an umbrella, like in parachute. You get a parachute over your head and you file intraposition, extraposition, TB, put her on ADT. We don't realize it that she probably had some spasm and we are pushing in 10 ml. Where will the dye go? Below we are putting HS cannula, upper tubes are in spasm, the dye is leaking in the endometrium, and we say she's got it, put her on ATT. So that's what I want to tell you, that don't do such a practice.
Sir, again you are muted.
Puja, somebody's muting me. So we shouldn't be pressurizing a lot of media inside and do it very gently. What I want to tell you, fluoroscopy is the key word. Fluoroscopy, fluoroscopy, fluoroscopy. In case you can do it, nothing like it. Water-soluble dyes, and I think that's it. And I'll go to something more relevant for both of you, for all of us. Insufficient dye or more amount of dye, more are bad. So dye should be taken in a very limited amount in a proper way, number one. Number two, pressure is not right. Don't use pressure because you can apply pressure. What will that poor uterus do, which has got a capacity of 2 ml? In case you do a 2D, 3D scan, on average uterine capacity of an infertile patient is around 2 to 3 ml. I do cavity mapping in every patient nowadays. So 3 ml is the cavity space, maximum 4 ml. The majority have less than 2 ml. And we are pushing in 8 ml. What will this poor uterus and tubes do? And finally, we don't get any answer. They have pain, they get injuries inside, they get admitted, and then a lot of things happen. So that should not be done. And we should avoid extraposition and intraposition. Getting a beautiful film which is showing you umbrellas everywhere, parachutes everywhere. You tell your friends, look at the ovarian artery, look at the pelvic veins, what beautiful HSG, and you take a picture and post on Facebook and Instagram. That is something different, but it's the wrong technique we have applied here. It may look good on Facebook and Instagram on your website that you have done a beautiful, good finding, but that is not correct. So when we look at an HSG, interpretation is most important. And interpretation we normally mask by taking large amount of media, less amount of media, more pressure, less pressure, and looking at the only tubal spill. So we'll follow the right protocols today and learn how to remove inter and intra-observer variability. Learn how to read an HSG. At least I don't need an ultrasound also to look at a polyp or an endometrial hyperplasia that is seen on an HSG. Okay. This is the normal film. Now I would request, in case you can participate, you can participate. In the end, we'll have quiz. You can participate there also. But here we're going to make it more interesting. This is a normal HSG film. Absolutely normal. Sometimes an HSG film, I request that the children, please, you'll have to. Please,
I'm doing. Yeah.
Remove the people who are talking, Pooja, please. Otherwise, I lose my frame of mind. Let's be serious about
Right, sir.
the whole thing. There are 261 people who are serious. Anyone who's making sound, please remove them. It's an order.
Thank you, sir.
We must
Okay,
respect
sir.
time
Sure,
of
sir.
260 people who have joined on a Sunday morning. We must respect them. So now, when we look at the whole pattern, I just change the color of my pen and we are here now. Many people say these are the beadings. Look at the film, bead aa gaya. This is bead, start ATT. TB PCR is always positive, negative. TB gold, everyone keeps doing, not knowing what we are doing, and patient goes on ATT. Now I'm going to tell you something. This is the tube as it is going. At some point of the tube may curl on itself, or the tube may have a turn like this. So when we see from here, we will find whiteness here. This is not beading. When the tube is getting knuckled, that is the point where we look at the knuckle and we say that there is an issue here. So look at this tube now. First of all, look at the cervix. Such beautiful arbor vitae. Look at this. This will tell you how beautiful her cervix is. It's a good cervix. When you see this, I'm happy. This means that it is this cervix, it doesn't have any infection. Follow how it is going up. You'll find that it's quite regular. This film is quite, I made it bigger, but this film is quite okay. There is no irregularity here. Very good film. And then we follow this. We look at the sphincter. There is no spasm, and very beautifully it is turning into like this. And then it is going, and there is some spill, which is not a very good spill, but spill is occurring here, spill is occurring here. So what we have learned from here is that we learned about arbor vitae. We learned about the lining, which is pretty decent. And we also learned that whenever the tubes get knuckled over them and we look at them from the front, we get knuckling point look white and there's not a bead. Now what is a bead? You'll ask me what is the beading. When you get a beading, you start ATT even if everything is negative. So now look at this now. A tube is going like this. It is a normal tube. A tube at some point of time will turn on itself. And this point will give you a beading. And even this point, when seen from below, will give you a beading. But what is actually a beading? Beading means this is the tube in which this endosalpinx. When due to some problem, this is eroded. The whole yellow thing is eroded. This means that now there is nothing yellow. It is eroded. So when the dye goes inside, dye will go inside this cavity. So this, which you see here, in a tube which is going like this, and you'll find this. This will be beading. In a tube which you're seeing, that you find something comes up in that tube, that will be beading. So a beading will look like something like this. This is the tube going with the white media in it, and here you'll find this is a beading. So I told you the difference between the endo.
You're not able to hear all this.
You can't hear me? Am I visible to all? Am I audible to all?
Yes, sir.
Yes, sir.
Somebody not able to- So it is like small berries growing on a branch of a tree. Small berries going on a shrub. That is beading, and I'll show you a lot of beadings today. Look at this film. Here, what has happened is that the cervix, probably the cannula would have gone higher, and then we can't see our arbor vitae here because the cannula has gone high. And then I can see Sandhya making a lot of notes. Sandhya and Garima on my screen making a lot of notes, as always. Look at this. Very lovely curvature. Don't jump to the cavity. Don't jump to the lining, the tubal lining. Look at this. Very regular, a very nice cavity. That's the way the cavities of uterus are. But this is a good cavity. Arbor vitae is not seen here. Missed it. Now, once we start following, here we'll find a beaking occurring. So beaking can be normal. We have a beaking here also. It's a beaking. So beaking is when it is beaking. It occurs nearly in large number of people. Beaking is not pathognomic of tuberculosis, but in case beaking occurs along with some beads or something, then we think about COX, but routinely we don't look at beaking as a problem. Beaking can be due to the coronal spasm also many times. Now look at this tube. Now I want you to be with me. Just be with me and understand what I'm telling you. Tube goes up like this, and here the tube is rotating and going, and here the tube is again knuckling. Tube is knuckling. So these are not the beads. So this is not a bead. Gentlemen, ladies, this is not a bead. Bead will occur on the tube, and the tube is going like this. A bead will occur when there is something like a berry growing shrub के ऊपर जैसे दिवाली की लाइट लगती है ना, ये bead होगा और bead अभी दिखाएंगे आपको. So this is a good film. But we have not ended here. Spill is the last thing on my mind. When I tell my students not to look at the spill, they say you're an idiot. Why? HSG is for spill. I say it is not for the spill. Spill तो दिखता है. Look at the tube now. In case you look at this tube coming down below, it is becoming going into the ampullary region now. Just follow this tube now. Don't you find rugosities occurring here? Do you find these mucosal folds here? Yes or no? These are mucosal folds. So
Yes,
whenever
we
you
get
see the mucosal fold,
Yes, sir.
when you see a mucosal fold, you know that her fundible or ampullary region is fine. This means that there is no infection. Whenever there is a bacteria coming up, in case we have any, this is a tube, and this is the fimbrial end. In case there is some infection coming up, what will go? This will become cicatrized, hardened. And the healing, it will calcify. Mucosal folds, they disappear. So now I'll draw something for you, which my teacher taught me 25 years back. These are the mucosal folds which are going like this. Something like this will go in. And we find that when we look at this, a dye will be here, no? Dye will come in the tube here. So when you look at in the screen, you'll find these things will become like folds. You'll have dye going into 3 lines. You'll find dye going into 3 lines like this. And dye will go like this. And you'll have these 3 black lines. Are you with me or not? These are the folds.
Yeah, we are.
These are the folds. Look at the folds now. Always look at the folds. That's very important. Don't ignore the folds. Folds ko, in case you are able to see the folds, half the battle is won. Now, people say that spill aa gaya, band kar do. That's the wrong way of doing an HSG. Do it very gradually. Let it unfold. Let the uterus grow big. Look at this. Look at the corneal end. Look at there. In case you apply pressure, in case you're traveling in a metro or a bus, if somebody just pushes you, you hit him back. Isn't it? You hit him back. Why are you pushing me? Same thing happens with the fallopian tube. This poor cornea is lying quiet, doing his own work. And now Dr. Sandhya is going to take 10 ml of media and opaque dye and just push it inside. What will this do? Go into close and push the dye back. And then we say, "Arey, beautiful. What a corneal spasm." It is a case of Cox, tubal block, ATT or IVF. Tubes are open. Okay, great. We see a lot of pictures now. Look at this. This is one of my favorite pictures which I want to tell people. In case you see this, you're done. Nothing can be more pretty than this. Look at this now. So what we're seeing here is we are seeing something like this. Something like this we are seeing. Now, this is what happens. This is the neck. Here we have endometrium and here we have endosalpinx. Transition of the endometrium ends here and salpinx starts somewhere here. At the point of this transition, there we get this knuckle and a line. There's a white line here in case you see it properly. In case you can see the white line, I don't know whether you can see it or not. You can definitely see a white line here. Can you all see? I'll erase it. Can you see this white line here?
Yes, sir.
Try to look at this line.
Yes, sir.
You see this line? It's a properly done HSG. You have allowed it to unfold. Such a uterus is a good uterus. When your endometrium is not going into endosalpinx in a very respectable way. Now, in case you put a lot of dye quickly, then this fold won't be seen. Then it will become something like this. And then this will get choked. Gussa aa jayega. This will get angry. The corner will get angry. It will say, go to hell. And then we will be very happy. Immediately laparoscopy. Laparoscopy means 50,000. Immediately IVF. That's actually criminal. You respect the woman's pornoa and you get good outcome. Look at this point here. Again, look at this black line and then it moves on. This is what I want to tell you. That's all. Look at this beautiful picture again. Can you see this black line here?
Yes.
Yes or no? Louder. I
Yes,
want you guys to talk.
Yes.
Yes,
Yes,
sir.
sir.
Yes, sir.
Yes, sir.
Sunday ke din you are missing your idli sambar and chola bhatura and paranthas. Let's talk for some time, then we can have double paranthas today. Okay? Okay. So look at this beautiful film. Cervix is not seen because this guy has again put in the whole thing till the internal os. We're very fond of internal os, I don't know. We just put in everything till internal os, screw it tightly, and then we lose cervix. I say cervix evaluation is a part of HSG. When I teach our teams OP or stimulation, I say look at cervical mucus. They say what an idiot he is. We are looking at follicles, he's looking at cervical mucus. Cervical mucus will tell you hormones, but we want to order a panel from SRL. 15,000 rupees, we feel very happy. E2, LH, progesterone. In case you look at cervical mucus, you'll know that there is enough estrogen in the patient. Good. So what we have learned here is that we are seeing a very nice utero salpinx junction, and the tubes are going and spilling. Now look at this tube now. This is called a primary wave. Look at this tube. It is going like this, and this tube is called secondary wave. This is a bowel. This is a bowel. This is a bowel. So when the dyes goes in the bowel, loops के अंदर आती हैं, तो I'm very happy. This means that everything is free inside. It's churning inside. When we have restricted bloshing here, then I'm worried. So in this case, we got beautiful. We have tubal uterine junction is perfectly fine, and we got good uterus. So cavity looks slightly small. That's okay. Primary waves on the left side and on the right side is we got secondary waves. Good spill in the abdominal cavity. So I'm happy. Look at another film. Again, you'll find that the cannula has gone till here, somewhere here. Not a right method. But again, you'll find this white line here. Look at the endometrium. It's quite nice. Nothing great. It's quite regular. The dye, you can see some folds occurring here. This fold. This is one fold, second fold. There's one fold occurring here. One fold, second fold. You may have some difficulty about these folds because you're not ever taught about these folds. But when you look at the HSG next time, the folds are seen. Some dye is lining the bowel. You're done. It's a good film. I don't like this eye. They always say that eradicate eye. But since I am now giving my experience here, this eye may be stupid. You find this waterfalls out of a sign. I don't find it very nice when I get a rigid straight tube This patient I'll keep on a watch, always on a watch. Because I feel that she may be having some problem, but presently she is fine. Look at this particular tube, uterus now. Similar patient, but look at the tubes, pretty nice. In the end, there's some spill is occurring, but her uterine cavity is small here. This is low cavity uterus. How do you know it's a low cavity uterus? You'll say that I have not measured everything, but always look at your cannula. You'll come to know that this is a low cavity uterus. So keep a watch on the low cavity uteruses many times. Our favorite is tuberculosis, and I'm actually an illiterate in tuberculosis because there's so much to learn about tuberculosis. I feel I don't know anything about tuberculosis. So I'll go to the fallopian tubes and not talk about tuberculosis at all. So when you go to the tubes, look at this tube now. Guys, please put on your speakerphone. Can someone comment upon this tube now?
This is a rigid tube.
It's a straight tube.
It is rigid tube. It is rigid tube, lead pipe.
Pipe rigidity.
Good. Cheers. We all win. We all win. Fantastic. It's a rigid tube. How do you know it's a rigid tube? One,
There is no fold.
no fold.
No way, sir.
No wave, no primary, secondary.
Fantastic. One thing you have missed it. Rigid tubes are always thick tubes. Why? This is a normal tube, which will be something like this. And you'll find this is a place which is seen. So when you put the dye, well, under the physiology of the dye goes in like this. So what we get is dye filled here. Dye is filled here. Okay, so dye flows in like this, and there is. You can look at how it looks like now. Look at this. This is the way dye will look like. Dye will go like this. Tubes are not seen. The dye is seen in the lumen. In a rigid tubes, what happens? This is the rigid tube. This is the normal tube. This is the muscularis mucosa of the tube. When there's an infection, it will be burrowing inside. It will burrow inside. And the rugosities will go. Now what will happen? This tube will become, the dye will become thinner or thicker?
Thicker.
Good. How do you find this tube is dilated? No? Just keep it in mind. I'll call it a lead pipe dilated tube. When tubes become choked completely, it can also happen that tubes can become totally thin viral tubes also. This is a thick dilated tube. Lead pipe tube will be my answer. And both ways is an unhealthy tube. And one bacteria which can affect the tubes is tuberculosis.
So one question, sir. So if the tube is thicker, then the HSG in that dye in the tube should be thinner compared to the normal tube?
No. I'm saying something different. Same thing to build up the topic. What you're saying is also right, but I'm trying to show you something. Now look at this tube. Fine. This tube, this is the white thing. Is that what you see? Yes or no?
Yes, sir.
Now when there is a bacteria, and bacteria is very fond of eating the endosalpinx. So to begin with, it'll start burrowing inside and it'll start eating this part. It'll eat this part. These parts are eaten, it's burrowing inside. When it burrows inside, what will happen? When you look at the tube now, the tube, all the rugosities are gone, tube will become thicker. It will be thick, flaccid tube. This will be the area. Now what you are talking is something more advanced. Where all these infections are going on, this is raw, this is raw, this is raw, this is raw. They start meeting each other. And when you meet each other, then the tube will become finally thinner, 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 and then finally it will be blocked. Initially, the muscularis mucosa, submucosa has gone. So tube will appear flaccid and thick. This tube is not only lead pipe, it is flaccid, totally flaccid. It's got no tone in it, toneless tube. And it may appear thicker. Same tube, when infection keeps occurring, it will keep eating and finally it will become choked at some point of time, and it may appear thinner at some point like this. But that's the way the whole physiology is simple mechanism of body's healing and response. So tube will look, yes.
It may be thinner.
Maybe thinner. It may become thinner later. I'm not denying it.
So first it is dilated and then it is thinner.
Yeah, normal physiology will be this only.
Okay.
So always don't look at a thin tube. Even dilated tube can be an issue.
Sir, is it early stage of self-anxiety or tuberculosis, this picture?
It is always. Strictures will come later. Initially, the TB infection will cut open these folds. And later on, the strictures will form. So we can never say what came earlier, chicken or an egg. But always look at it that when these things are occurring, they all occur simultaneously. And we have to keep a watch. TB ke andar, there are around 10 markers of presentation in the tube. I'll be sending you those articles, very, very beautiful articles, mind-blowing articles. I'll send to you. They'll remove all your queries. It can be cheesecake pattern, it can be a retort pattern, it can be a cobblestone pattern, it can be a roseate pattern. There are around 10 patterns of the tubules, club tubes. I'll send you everything in some time. We just understand the physiology. Now look at this tube lying here. Now this tube is coming from here and going and then probably moving up. So these tubes are flaccid tubes, flaccid dilated tubes. So the tubes can, with infection, it's not that the tubes, they always become thinner and get choked. They can become thicker also. Now look at the blockages occurring here. This is an hydrosalpinx. This is an hydrosalpinx club-shaped tube in the end. But here the tubes may be thinner, and as we're going ahead, tubes are becoming thicker. It's a normal physiology. Just keep your mind open and understand. We cannot learn or unlearn what we have learned in past 20 years, 25 years. Today I'm opening a new Pandora's box for you.
Sir, it is said that during active infection, HSG should not be done. So this seems like to be active infection.
Not to be done where, ma'am?
HSG.
Not to be done where?
If active infection of tuberculosis.
Infection, I think.
Never do. So that's what I'm saying. When the patient comes, what do? Morning I do 2D or 3D or B mode 2D with color Doppler. I have already done it, no? Because I find things, I won't confirm it. I find an endometrioma, I won't confirm it.
Okay.
That's what I'm saying. Well, in the morning, I always carry out at 20 millimeter size follicle or 18 plus. So endometrium grows. In case endometrium is not only grown, I can't get much of idea. The endometrium has to grow. When endometrium grows, then you can see a polyp. Fine. Then you can see some changes in the endometrium.
Excuse me, sir. On day 9, it is not possible to get a 20 mm follicle every time.
I never said 20 mm follicle. I just go back. I never said that. I told you it is any day when it is maybe 9th day or 12th day or later. Whenever it is 70 to 18 millimeter, then I do. I agree with you. I've never told that. I'm just saying
but it is usually said after day 10, we should not do HSG.
Ma'am, HSG, now move one step ahead of that, no. HSG should be done in follicular phase. Till the time she's not ovulated, she's in the follicular phase.
So, but we have to rule out active tuberculosis before that.
To do a scan. You don't rule out tuberculosis in every patient. How do you rule out tuberculosis? You don't do biopsies for all.
Yeah.
There is no test to rule out tuberculosis. You keep doing gene expert. In so many cases, we get gene expert positive in the people who don't have any symptoms. Or people who are having symptoms, they are negative. So there is no role of ruling out tuberculosis. Please remember this. In IVF, we don't rule out tuberculosis until it's indicated. In case you though this, we've already had this talk around 3 hours, and we talk for our batches. Whenever endometrium is good, HSG is good. We don't rule out tuberculosis. Tuberculosis is not to be ruled out.
Okay.
And the only way to rule out tuberculosis is doing gene expert plus HPE, which follows the DNC. DNC, you are charging them 1,000 rupees on average. HPE is 2,000 rupees. Gene expert is 4,500 rupees. So you're billing the patient around 9,000 rupees to diagnose TB for all. Not to be done. Clear cut, not to be done.
So Montox test may give some.
Ma'am, you can do, but Montox is a very anyway, I won't go to TB here.
Sir, what is the relation between the follicular size and the HSG, sir?
Ma'am, I won't talk to this. I'll just come to move ahead.
Okay.
Otherwise, I'll come in the end. Otherwise, I'll.
Okay, sir.
Those are
Okay.
beautiful films I've showed to you.
Okay, sir.
I told you we won't go into theory.
Okay.
I'll show you things which are important for you. Look at this tube. Look at this tube. What do you feel about this tube now?
Dilated blocky.
Flaccid dilated tube. Good. Very, very good. Is this a bead?
Yes.
No,
Knuckle.
no.
Knuckle.
It's
No,
not.
No, sir. Knuckle.
Not a bead. Knuckling.
You are brilliant. You all are brilliant. Look at this angle. What type of uterus is this?
This is a
Septate.
septate uterus.
It can be septate. It can be
Sir,
bicornuate.
there is no
I will
fundal,
have to see
fundal
the outer
dimpling.
contour, sir.
Fundal
Yes.
dimpling.
Agreed. I'm just saying that angle should be more than 105 degrees obtuse to for an bicornuate uterus.
Yeah. And this angle is less.
Yeah, angle is less. I won't go into this teaching because this is, you all know it, or we lose our time. Look at this particular uterus. Lovely. What do you find here?
Looks
Big
pretty-
block.
This is arcuate uterus and retort septate tube, left side. And no spillage.
This
No
may be
spillage.
bicornuate uterus also. Maybe bicornuate uterus. Maybe. I don't know. But it's in hydrosalpinx. And there is a block.
Yeah.
Good.
Femoral block.
Femoral block.